Case one was side branch occlusion, which happened during the professional stenting. We had the OCT images of this pre, but we probably didn't read them so well. So there was side branch occlusion after the dilatation of the distal left main, and the circumflex completely closed. Now, I have reanalyzed these images as to what was going on. And if you see here, the carinal tip angle was pretty narrow. It was about 30 degrees or maybe less than that. It looks less than that. Carina is kind of protruding in, and it's kind of equivalent to eyebrow sign if had we used IBIS here. The branch point carinal tip distance, which we measured in the OCT machine, came to about 1.43. So we had these predictors. And I have not put the images. I had shown the images earlier in my talk there. There was considerable lipid plaque burden, both in the main vessel at the level of the origin of the side branch. And I had marked it with the yellow arrows. So this was a lesion where the plaque burden was considerable. Unfortunately, on OCT, you cannot measure the plaque burden because the penetration of OCT is pretty low. So this is what caused the loss of the side branch here. So as was being mentioned, we tried wiring. The first wire went into the OM branch, and then we left it there, acting as a landmark, and then we put the second wire, which probably went through the distal strut into the vessel down below. We opened the struts, and then we did a tap. We did the ostial placement of the stent. We did the kiss, and the most important thing here to do is that you have to do the simultaneous deflation. If you don't do that, you will have it being changed into a reverse crush. So this is how it looked post tap. So the side branch was salvaged, and we had a fairly good result. Now, this was the post PCI OCT, and which showed the carina was pretty good. There was a position all around. You can see that the position indicator is all white. This was the distal edge. This was the metal-free carina, and this was the proximal stent edge. So everything looked good. Now I come to case 2, where this was the lady who had undergone a provisional stenting when she had presented with STEMI and cardiogenic shock. And she came back to us with class 3 angina, and she had the vessel hanging. So we obviously had to stent this vessel because there was absolutely no relief. So we thought of tap, reverse crush, or mini culotte. These are the bailout techniques which you can, any of these three you can apply here. So we chose tap, and this was the first OCT, baseline OCT run, which we took. And what we noticed was that at the circumflex ostium, there was a lot of thrombus. So there was probably an unstable plaque which had ruptured there, and that is what had caused her to develop class 3 symptoms. So overlapping stent struts, white thrombus of the circ ostium, and very well endothelized left main stent. So we went ahead with the tap. We opened the struts with 2x10 balloon. We used a 2.5 millimeter balloon at extremely high pressures to displace the stent struts. We did the placement, and mind you, when you do a tap, you have to get the side branch stent to match the proximal edge, and the distal edge obviously is going to hang. So you have to have some amount of protrusion. So we had the stent boost help us. You deploy the stent at nominal pressure, pull back the balloon, and then go to extremely high pressure. Why? Because you have metal struts which are hanging, which you obviously dilated with very high pressure balloons, but we want to ensure that. So we then did a small kiss. Now, this was being done in an endothelized stented left main segment. So we didn't have any major concerns here of causing any dissections or anything, because this was a metal scaffold which was fully endothelized. And this was the OCT pullback. As you can see, you see the freshly implanted stent. You can even make out from the rendered view that these are Zions platform stent. And as you approach proximally, these are endothelized stents. And the carina was absolutely metal-free. If you can see the ostium of the LED, you can see a layer of stents hanging inside, which are appearing red in color. So we had achieved to make a do a perfect tap with these stents protruding at one of the edges. So this is how it looked. This was the circumflex with freshly implanted stent, LED ostium. You had the overhanging stent struts at the LED ostium, the left main, and metal-free carina. And then we did our run from the LAD to the LMCA. And as you can see, the ostium of the circumflex is absolutely free. And you see one layer of freshly implanted struts which have been plastered onto the left main. Now here, if you see, the stents are fully endothelialized. These are the old stents. We've done nothing except for one layer which we've added at the distal edge of the left main. So everything looks beautiful. Left main, LED, endothelized stent. This is the crushed circumflex stent over the left main and the overhanging struts. And in the cross-sectional view, we could see overhanging struts at the circumflex. So this was the final run of the patient. Thank you.